Hello and welcome to the PrecisCa Multidisciplinary Genitourinary Tumor Panel. My name is Jason Abel. I'm a urologic oncologist at the University of Wisconsin. To begin, we'll just go around the panel, introduce yourself and your expertise. Dr. Melnick.
My name is Vincent Melnick from Washington University in St. Louis, and I'm an abdominal radiologist.
Hi, my name is Matt Reddick. I'm a medical oncologist specializing in genitourinary malignancies.
I'm Larry Keston, a radiation oncologist in the Detroit, Michigan area. I'm the medical director of the Michigan region for MHP Radiation Oncology Institute and Genesis Care.
Yes, I'm Ethar Derwish. I'm a urologic oncologist at the University of California, San Diego.
This patient is a 79-year-old gentleman who was in 2010 treated for prostate cancer. It was stage T3B. He underwent a robot prostatectomy. The final pathology was Gleason 4+3=7, grade group 3 with a tertiary pattern of 5. He now has a slowly rising PSA, and an Axumin PET scan showed hypermetabolic lesions in the prostate bed and the right iliac lymph node. So among the questions we're going to discuss today is whether we recommend treatments of both sites or only the prostate bed recurrence. If we're treating just the prostate bed, which treatment modality would be best? If we're treating both sites, which treatment modality would be best? And what is the role of androgen deprivation therapy in this patient? So the patient presented with an ECOG performance status of 1. The past medical history includes coronary artery disease. He had a coronary artery bypass graft in 2005. Oncologic history, when he presented in 2010, he had initial PSA of 6.9. His prostate biopsy shows Gleason 4+5=9, and his clinical stage was T1C. He underwent a robot prostatectomy, and the final pathology showed Gleason 4+3=7 with a tertiary pattern of 5. The pathologic stage was T3B, N0, M0. The margins were negative. There was extraprostatic extension and right seminal vesicle invasion present, and 0 out of 4 lymph nodes were involved. So, Dr. Derwish, can you describe how extensive of a lymph node dissection do you think is standard these days with prostate cancer? And do you adjust the extent of your lymph node dissection in patients who present with high-grade disease or aggressive tumor features?
Dr. Abel, that's a great question. I think that if we're going to be, depending on NCCN risk category, for example, if this is a patient who has a high risk category on let's say biopsy, so he had or clinical stage 3, Gleason grade 5, and you have and the nomogram MSK or Catan demonstrates let's say a risk of lymph node metastasis of 10% or more, then certainly obtaining imaging to risk stratify, and also considering an extended pelvic lymph node dissection that doesn't just include the external iliac nodes or the obturator nodes, but also goes further up the hypogastric chain, would be considered in this situation.
You know, with any medical procedure, there's risks and benefits. When you're describing to a patient the risk and the benefit or the potential benefit of a extended lymph node dissection for prostate cancer, what things do you discuss?
I think you're going to have to discuss the risks of vascular injury, in addition to discussing the risk of lymphoceles that may require secondary procedures, in addition to the risk of nerve injury, such as obturator nerve injury. All of these should be discussed with this as part of the discussion, but also within a risk with an individualized risk-benefit discussion with the patient. And of course, this is with patients who we are assuming have the appropriate life expectancy from a multi-system standpoint.
After a patient like this is treated with prostatectomy, how do you counsel them about the risk of recurrence? And can you comment specifically on how the tertiary pattern 5 and the stage in this patient could impact your recommendations?
I think a patient who has a grade pattern of 5 and or who has extra capsular extension that is should be a candidate for adjuvant radiation therapy and should be counseled with respect to a higher risk of local regional recurrence as well as potentially distant recurrence. And depending on the patient's other risk factors, that's something, and from a systemic standpoint, should be discussed with the patient postoperatively. Patients who obviously have positive lymph nodes should be also being considered for androgen deprivation therapy as an adjuvant too.
Dr. Keston, could you discuss the role of adjuvant versus salvage radiation in a patient of this type?
Certainly. Oftentimes, if certain pathologic features are noted at the time of surgery, then we would recommend adjuvant radiation treatment or observe the patient more closely with consideration of potential salvage radiation therapy later. For adjuvant radiation therapy, some of the factors that might make one choose to add radiation treatment after surgery would be a positive margin, extracapsular extension, or seminal vesicle invasion. In this particular instance, the margins were negative, but there was extracapsular extension and seminal vesicle invasion. And another factor that sometimes leads one to possibly choose a slightly more aggressive upfront treatment approach is the grade of the tumor, which is the Gleason score, of course. And in this particular setting, the pre-treatment biopsy was a Gleason score of 9 with tertiary pattern 5. The pathologic specimen had a Gleason score of 7, but also had tertiary pattern 5. I mean, one might consider this a slightly more aggressive case and might offer adjuvant radiation treatment. More recently, especially when the PSA drops to undetectable following surgery, there has been a bit of a tendency to approach these patients with an active surveillance approach where we monitor the PSA very closely. And then if the PSA were to rise, then we consider salvage radiation treatment at that point. So there is not a clear recommendation one way or the other. Either approach is appropriate in this particular situation. You know, myself being a radiation oncologist, I suppose I would lean toward adjuvant radiation treatment in a case like this, but it certainly would be a very reasonable approach to observe and consider salvage RT at a later point in time.
Can you describe a little bit the radiation field, what that encompasses? And is there any evidence for concurrent androgen deprivation in a patient like this?
Yes. For patients treated postoperatively with radiation treatment, the target always includes what we call the prostate fossa, which is essentially the surgical bed or the previous location of the prostate. That is the primary target. We sometimes add lymph node treatment. Again, that is a controversial topic and can be based on many factors, whether you consider the extent of the lymph node dissection that was performed, the likelihood of the lymph nodes being involved based on the pathologic features, and referencing some nomograms and such as what Dr. DeWeese recommended or mentioned with the Catan or MSK nomograms to determine the likelihood of lymph node involvement. But right now, at this point in time, whether to add the lymph nodes or not following prostatectomy with post-operative radiation treatment, it is a controversial subject. I personally tend to treat the lymph nodes in this situation, but it is either approach, again, is appropriate. The prostate fossa is the target that would always be included regardless. The addition of androgen deprivation therapy is a little more standard, especially in a setting like this patient with a higher tertiary pattern 5 Gleason score. But in the post-operative setting, in some large randomized trials, it has been shown that adding androgen deprivation to radiation treatment in that situation does provide higher disease-free survival rates. So I think it is probably a more common scenario to add androgen deprivation therapy to a post-operative radiation treatment in this situation.
So we can see the patient's PSA pattern here in 2011, and really up until about 2014, it was not detectable. And then really it starts to rise and double very quickly just with since 2019. Dr. Melnick, could you comment on the imaging to the side here?
Yeah, these are two images from an Axumin PET CT. This is a relatively new tracer that's primarily approved for detecting recurrent cancer in patients who've had prostatectomy. And you can see on these images that on the top image, it's through close to the prostate bed, and on the patient's right side, there's a rounded orange colored area. What that is a mass near the right seminal vesicle that has taken up the tracers. So this is an amino acid that tends to be taken up by prostate cancer cells, and it's attached to a radioactive substance that emits photons and is detected by the PET CT scanner. So that's a very good look for recurrent prostate cancer in that location. It's hard to see on the bottom image what the finding is, but it's actually a nice demonstration of the benefit of Axumin, because there's a very small sub-centimeter iliac chain lymph node posterior to the artery. And I think on conventional CT, almost every radiologist would call that a normal lymph node. It's less than a centimeter in short axis, and we would just say to watch it or to just note its presence. But on Axumin, there's a little bit of increased tracer uptake. And so we'd be worried about a lymph node metastasis there given that finding.
So Dr. Reddick, could you comment a little bit about this patient had a slowly rising PSA. At what value are Axumin PET scans sensitive for detecting metastatic sites? And could you also comment, I know your center uses PSMA PET scans, and how these may be used in similar patients?
Sure. So the Axumin PET scan is an excellent scan for trying to identify the site of disease in a patient who has a PSA recurrence, such as this patient. At low PSAs, certainly less than 1 and even less than 5, the Axumin scan is not very sensitive. In this case, the patient had a PSA of 2.7 and had detectable disease. So in this case, the Axumin PET was useful. If the Axumin PET had been done when the PSA was lower, less than 1, when it was 0.3 or 0.62, it would likely not have detected the recurrence. The PSMA PET scan is a newer scan. It's going to be probably more widely available in the coming months. And that is really the best scan. It's been tested head-to-head against the Axumin scan in this exact setting, and it outperforms it. So the PSMA scan can detect recurrences even when the PSA is as low as 0.2 to 1. So, and in this patient, if the PSMA scan were available, I would do it. And the reason why I would do it is to try to identify other sites of disease, including distant metastatic sites. And that's not infrequent in patients who undergo a PSMA PET scan with a PSA that's this high and in the context of this patient's history. I should also point out that when performing salvage radiation, it's, I think, ideal to try to do it as when the PSA is as low as possible, because that will be associated with the greatest potential benefit and control of the disease long-term.
So, Dr. Rettig, when this patient presents to your office in 2021, has a PSA of 2.7 at this time, what are the options for treatment that you discuss with the patient?
So I would, assuming we're just working with the Axumin PET scan, I would recommend that the patient have radiation both to the prostate bed as well as to the lymph nodes, and with a boost to the involved lymph node. And I would use it with concurrent hormone therapy. And there are two options. There's the shot known as Lupron, which is very similar to a surgical castration. It's called a medical castration. Again, not a very palatable term, but the term that we use. And that would typically be done for 6 months. There's also an option to use a high dose of an anti-androgen, a pill that blocks the male hormones called bicalutamide. And both the Lupron and the bicalutamide have been shown to improve outcomes in this setting. The bicalutamide has an advantage of probably fewer side effects, but it's typically used for 2 years in a high dose. And the high dose of bicalutamide is something that can certainly be used. If it were the Lupron, it would be 6 months. Should also point out the benefit of adding hormone therapy to salvage radiation is largely seen in patients like this, where the PSA is greater than 0.7, and especially in patients whose PSA is greater than 1.5.
Dr. Keston, could you comment now, the patient in 2021, do you recommend treating both sites? And then could you also comment on the role of androgen deprivation therapy? How long would you recommend that if you do?
Yes, certainly, Dr. Abel. First, I would say that I agree completely with the excellent comments of Dr. Rettig. It certainly would have been ideal, probably, to start salvage radiation treatment earlier in this setting. It also might be more ideal now, if it's available in your area, to get the PSMA PET to better stage. In this scenario, with 2 sites, I would definitely agree again with Dr. Rettig. I would treat both sites. I would also treat the pelvic lymph nodes electively. And so we would give an initial lower dose to the prostate bed, the elective lymph nodes, and the lymph node, including, of course, the lymph node that's involved on the Axumin PET scan. And then we would boost to a higher dose to both the location of gross disease in the prostate fossa, including that right seminal vesicle location, and the involved pelvic lymph node. We would also, of course, add androgen deprivation therapy, as Dr. Rettig indicated. Regarding the length of androgen deprivation therapy, that is a controversial subject, but in a scenario such as this, one would typically use a longer-term androgen deprivation therapy regimen, certainly at least 6 months, but probably more along the lines of 18 months or 24 months, depending on what Dr. Rettig, of course, would recommend.
So in summary, in a 79-year-old gentleman who was treated with radical prostatectomy for intermediate risk prostate cancer, 10 years later has a rising PSA and 2 hypermetabolic lesions, one in the prostate bed and one in the iliac lymph node. The multidisciplinary panel discussed the next steps to consider would be radiation to both the iliac lymph node and the prostate bed, in addition to concurrent androgen deprivation or a combination of high-dose anti-androgens for 6 months, considering out to 24 months.